Welcome to the UK Dementia and Palliative Care Conference 2025 podcast, brought to you by Rowcroft Hospice. Recorded at the beautiful Buckfast Abbey Conference Centre in Devon, this series explores the critical role of dementia and palliative care in supporting those living with dementia. Across these episodes, we'll be sharing expert insights, real-life experiences, and innovative approaches to improving care. Thanks for tuning in. Let's get started. Promoting continence and managing incontinence within the context of dignified dementia care. Presented by Dr. Zena Aldridge, Independent Dementia Nurse Consultant and Social Care Nurse Fellow, NIHR Nursing and Midwifery Office.
I have to say, following Liz and Wilco, I feel a little bit like an imposter. Thank you for having me here. I'm coming at this from a very different perspective. I've worked in dementia care for 30 years, and I went into dementia care because of the experiences of my family caring for my great-grandmother. And one of the things that I remember is my aunts and my grandmother having to really struggle as a family to look after her. And you think, I'm talking about 35 years ago when we didn't even call dementia a lot of the time. But continence was a real issue for them in terms of looking after her at home. And it's always resonated with me as both a family member but also as a professional. So I have to say, I'm going to cut to the chase here. I don't get invited to many dinner parties because I talk about death, dementia and continence issues constantly. So you'll kind of get a sense of where I come from this. So I kind of struggle as a nurse I didn't see my place in research as a junior nurse. I didn't understand what research was. I thought it was something that happened in academic institutions, a long way from me. I'm not a natural academic. I was a diploma nurse. I'm proud to be a diploma nurse. Didn't start off my career with a degree. So certainly for me as a postdoctoral nurse now, it's a bit still mind-blowing. Hence, I still feel a bit of an imposter. But I think this definition of research is really, really important to start to break down what research is and what it isn't, because we have research with a little r, that as a clinician, I think I do on most days. I deliver person-centred and relationship-centred care. I'm not a medical model nurse. So when I'm faced with someone who I'm supporting, whether that be a person living with dementia or their family carer, they will have a need that I can meet in multiple ways. And I have to determine what the best way is to meet that need for that individual. So there's no algorithm, there's no decision tree. So I'm constantly doing sort of that low-level research in the back of my mind to think about what is the best evidence and how can I meet that need. And I think if we start to break down that, it starts to demystify research and make us all feel like we've got a part of it. So this definition, which says the creation of new knowledge and or the use of existing knowledge, which I think is really critical here, in a new and creative way, so as to generate new concepts, methodologies, and for me, the most important thing, understanding. But one of the challenges is a lot of the evidence doesn't end up reaching us on the front line. So continence care particularly is an issue. When you think most continence care is delivered by family carers and social care staff, it's not delivered by academics, it's not delivered by often nurses and doctors. It's on that, very intimate level in those intimate relationships, both at home and in social care settings. So we need to think about translating the research into practice, into meaningful things. That knowledge mobilisation that Liz talked about is so critical. And translating research into practice is applying research findings to real-world health, social care and public health settings to improve outcomes, experiences and the quality of care. Now, you'd think it would be easy, wouldn't you? It's absolutely not. And there are many reasons why. The biggest one for me is this. Most of the information sits in a wonderful academic institution, high-impact factor journal that most normal people delivering social care or delivering person care to their loved ones will never see and never access. Or it's written in a way that doesn't kind of translate into the real world life. And I used to find that incredibly frustrating. My other job is I work as a social care nurse fellow for NIHR. A lot of social care nurses can't even access an academic journal. They don't have the ability to get into a library to bring that information down. So for me, it's kind of how do we do this? As practitioners, clinicians, lay people, how do we get access to that information? So for me as a practitioner, as I said, incontinence has always been a thing that has bothered me, interested me. I've thought that actually it's such a big indicator in terms of people going into long-term care. It's very often a cause of falls, pressure areas, carer burnout. It's really, really detrimental. But also in terms of dignity. I find it really interesting that we've got these adverts on telly now that say a little bit of wee doesn't stop me, and they advocate a pad. I want to know how I resolve my issues with incontinence, not just have a pad that resolves the excrement that I lose. And we've had lots of research over recent years. Katie Featherstone had a fabulous piece of research talked about the pad culture. So the minute that someone is incontinent, we offer them a product as opposed to look to the underlying cause. I'm a middle-aged woman. I don't want to think that that is going to be inevitable. I want to be able to think that I can resolve some of that myself. So I knew as a practitioner that incontinence was an involuntary loss of bladder or bowel control. And I know that it's stigmatised. I also knew that often there was this belief that for people living with dementia, there is nothing that can be done and it's inevitable if they develop dementia. I also knew that it isn't inevitable, it's not a normal part of ageing, but I'm a dementia nurse, I'm not a continence specialist. So it was really difficult to know how do I support families to improve their outcomes. And you'll notice I always talk about promoting continence and managing incontinence rather than only talking about incontinence, because that's a really important shift in the language. Incontinence sounds like it is inevitable, but if we think that there is something that can be done, promoting continence is a really key message. But lots of families that I worked with felt that nothing could be done. Now, as a nurse, I would often, if I was case managing and supporting a family affected by dementia, I'd often think, right, I've identified a continence problem, so I'm going to refer to my continence colleagues. And to a degree, I thought that was job done. I thought I'd almost tick that box, and those were the experts in continence, and they were going to be able to support that. But I still found that families were saying to me, well, they've offered me a pad, they've offered me some equipment, or they've told me to go to Boots if I'm not eligible for resources. And again, as a family, how do you know when you go to this? I mean, I don't know if anyone's looked at the continence products in Boots of late. There's reams and reams of them. How do you know what's the right product? What is it that's going to work for you as a family? But what I saw in my practice was the impact of poorly managed incontinence. Poorly managed continence. So not only that inability to access the most appropriate support, because a lot of my continence colleagues would say, we don't really understand dementia. And then the dementia specialists say, well, we don't really understand continence. So you've got this bit in the middle where we've got this gap in knowledge. The compromised dignity, it's incredibly difficult for people to accept that they're struggling to manage their continence needs. They don't want to talk about it. It's an embarrassing thing. People try to hide it. For me, one of the things, again, that we don't address within this is the impact on people's physical relationship and intimacy. Dementia takes so much away from couples, families, that lack of being able to show intimacy, have a hug, or sleep in separate beds because continence affected. How much of a detrimental impact does that have on families? The need to think about how it impacts more widely, so the urinary tract infections, falls, all of those things are entangled within it. Pain as well, actually, and I'll come to a case with that shortly. The thought about the financial impact and the workload for a family carer who might already be struggling to support the person that they care for. Extra washing, extra, cleaning carpets, all of those kind of things, how difficult that can be. But then you start to think about the negative relationships, the resentment, the number of families that I've spoken to, and their tipping point is the point when the person can no longer manage their continence needs effectively at home, and furniture and carpets are getting soiled, and they say, I just can't do this anymore. Thinking about the increased risk of hospital admission, falls, fractures, and actually social isolation and depression. If you know that you've got a risk of being incontinent when you go out, it's likely you think, I'm not going to go there. COVID was really quite an exacerbator of this, when a lot of public toilets got closed. Supermarkets would close their toilets. So people were like, I can't go out because there's nowhere that I can go to the toilet or I can change my products. And I will talk about a lady who really highlights that later on. So I kind of knew all this stuff, but I didn't know where to go with it and how to challenge it. Now, I then met this inspirational couple who will... As practitioners, we always got those people that really stick in our mind, and this couple really stick in my mind. So Joe and June, not their real names, and this is not a photo of them, just for full disclosure, and to reassure you, were a wonderful couple that I'd supported for several years. June had early onset dementia. Joe had been looking after her beautifully at home. They had no formal care. He used to take her out everywhere. She was always immaculately turned out. Her hair was done, her nails were done. He used to cook meals from scratch. They were completely besotted with each other. She was quite non-verbal. She had very limited communication, but their presence and body language communicated so much. And he disclosed to me that he was really struggling to meet her continence needs. And he was really frustrated and angry because he'd been seen by a continence specialist nurse who had prescribed pull-up pads for during the day, but pad and pants at night, because they were cheaper. And they didn't think that she needed more than 3 pairs of pull-up pants a day. Now, this frustrated him because actually the pull-up pants were not alien to June. They felt like normal attire. So she was fairly able to pull up pants up and down. When he started to have the net pad and pads, she found that alien, so he would find them secreted, she'd take them off, she'd resist the personal care. He was then finding it really difficult to maintain her personal hygiene, and he really didn't want to go down the route of having a carer come into the house. He said, I can manage, but I just need the right products. So I naively went to speak to colleagues and said, why can't they have the pads? And they said, well, we have an algorithm for prescribing, which means that this is the only amount of pads that we can prescribe in a day. And I said, but what about their needs as a collective? I get you're talking about containment, but actually this is a much bigger issue than containment. So Joe and I set off on a mission to change the algorithm. And say, do you know what? Actually, you need to think about the cost in terms of the system as a whole and the personal cost to this family. Actually, yes, it might be cheaper now, but if this lady needs care, if he can no longer cope and she needs to go into residential care, surely that's going to be far more expensive than you prescribing pull-up pants for over the 24-hour period. This was not an easy feat, can I say? And this was in one CCG area about 10 years ago. I couldn't even tell you if they're still adhering to it, but it felt like a victory. And I know from conversations I've had elsewhere that others have taken up the chalice in trying to prove that this is important. But we set about it. How did we do it? I started to be a curious clinician and think, what is there that we know in the research that I can take to them to prove that actually their algorithm is wrong? It's not inclusive, it's detrimental. And as I say, I'm not a natural researcher. I am a curious clinician. I'm always the one that, when I was doing my nurse training, I'd be the one at the end of 5 minutes before the end go, can I just ask? When everyone used to throw things at me and say, shut up, Zena. They still do that now. But for me, it's always like, well, why do we do what we're doing? Why can't we do it better? Well, how can we improve it? So if you've got a mind like that, you can easily do some research, whether that be desktop research or going into academia. So I found out that actually we looked at the data in terms of the frequency of incontinence and the issues that it faced. We looked at the prevalence. We also looked at the fact that there was data that talked about the emotional and psychological impact of people living with dementia and their family carers when continence was poorly managed. So whilst intuitively I knew some of this stuff, I could go and draw down the research and say, this is not just my opinion, this is what the evidence says. We could say about the known harms. So again, harms are a really good tool in terms of changing behaviour. So when you start to say to people, well, actually, if you don't do this, this person might fall, they might fracture, they might end up in hospital, suddenly the pound signs go up. So whilst I'm coming at it from a quality perspective, it enabled me to have some of those levers that Liz was talking about earlier. And also we were talking about these adverse health outcomes that are associated with poorly managed continence. So again, you start to say this is not a situation in isolation, it's part of a bigger issue. We're all very good at working in our lanes. You know, looking at singular diseases or problems. And actually, sometimes we need to start thinking this way about how does A influence B, et cetera, So I think, again, understanding how the systems work and the levers you need to pull is really important. It's complex. It's not straightforward. So we're not just talking about containment here. We have to really press home on the evidence that's out there in terms of not only the physical, but the psychosocial impact of poorly managed continence. For this couple, it really articulated to me in really clear terms, and he was so beautifully passionate about the care that he wanted to provide his wife. It wasn't difficult to give him the tools to be able to create the argument that enabled us to facilitate change. There is still so much stigma. I would say that families affected by dementia are very rarely asked about the issues around poorly managed continence. And of course, there might be people who've lived with incontinence for many, many years who then develop dementia, and it makes it even harder for them to manage their care needs. So we need to kind of challenge this perception that it's normal and it's a symptom of dementia. And of course, we know that the products are often poorly designed. They're not necessarily available for these purposes. And we kind of were able to use the work that Kathy Murphy has done to kind of really illustrate that. So we also argued that to conduct an assessment, you actually need to know more about the person and how they're experiencing dementia, and have they actually had an underlying assessment of what might be causing their continence issues. And sadly, all too often, practitioners think that incontinence is a symptom of dementia. Actually, it's not inevitable. It's more likely in the latter stages, but that's often associated with the functional issues around being poorly mobile, being unable to communicate needs. So we have to start looking at beyond the diagnosis of dementia. All too often, when someone gets a diagnosis of dementia, everything that happens to them after that is, it's their dementia. You know, God forbid they have other health and social care conditions that need resolving as a result of that. But there is a skills and knowledge gap. But as I said, I think there's this bridge that needs to be built between different specialisms to understand how we do that more effectively. And we need to be open-minded. All of these issues here are relevant to people living with dementia as they are anyone else. Yet I have spoken to lots of family carers who have said that none of this has been discussed with them. So even when we think about functional incontinence, which is often far more likely to be the contributing cause, particularly in the earlier stages, how are we supporting people to think about, is it actually that they just can't undo a fly button anymore? Do they need clothes that are easily accessible because they've lost dexterity? Do they know where the bathroom is anymore? Do we need to put the signs on the toilet? You know, because if they're losing language and communication, that ability to identify when they need to go to the toilet and ask can be really difficult. I'm going to overshare with you now, which is not unusual for me, but I went to Morocco once on holiday, and my ex-husband was Moroccan, so I spoke pidgin Arabic, I would say. We were in Marrakesh, and I actually decided to wander off into the souk on my own, just have a little wander around while I was waiting for friends before we met for supper. I was completely distracted. There was lots of snake charmers, there was street food. I was very blonde and slim. This is a long time ago, so, you know, I got the odd smile, which was lovely. And I didn't really pay any attention to where I was going. And then I was in the middle of the market and thought, I need to get back to my hotel. And I couldn't think where I'd got to go. Now, because I got anxious, despite the fact that I could speak Arabic, I couldn't process that language into my mouth and get it out. My mouth went dry. I started to look quite agitated. There was a lot of hand-wringing, red and sweaty, probably sort of pacing on the spot. People were giving me a wide berth. And then suddenly someone just tapped me on the shoulder as if to say, I can see your distress, just wait there. And she got this young man to come and ask me what the problem was in English, which I found bizarre because I thought I could have been German or Norwegian or anything, but clearly they get a lot of English women in the souk looking a bit distressed. And he was able to, support me back to my hotel and all the rest of it. But at that moment, I was so distressed. When I get anxious, most of us then have that trigger of wanting to go to the bathroom. If you're in Morocco, trust me, the toilets look nothing like they do in the UK. So again, and it made me think, is that any different to how someone with dementia might feel in that moment? So I guess for me, it's about how do we put ourselves in those shoes? So we have got the brain changes that affect people living with dementia as well. So we know that they have changes to the nerves and the muscles and the hormones that can cause more likelihood of developing issues with continence. But again, if we know this, we can start to think about how we can resolve it and overcome it. We can also think about the muscle changes. So we've talked about sarcopenia has been mentioned before. So that change in muscle and tone. So again, are we encouraging people to do pelvic floor exercises, for example, for the ladies and various other things that actually we can be thinking of in a preventative manner. But if they do happen, explaining what is happening to the family and trying to override some of those issues. It could well be that the person has other comorbid conditions and that might be impacting on their continence, or the medication that they're taking for those comorbid conditions. I saw a lady coming back to COVID who actually became almost housebound because what had happened for her was that at the beginning of COVID, she was functioning at home in housing with care. And her daughter was a bit concerned that she was going to be on her own, so she moved her in. And she noticed that her mum was going to the toilet constantly, like every 10 or 15 minutes, her mum would be going to pass urine. She'd find soiled incontinence pads for when her mum hadn't been able to get there. And then her mum wouldn't go out because her mum was worried about soiling the car seat while she was in there. So it became more and more of an issue for them. And I was asked to have a chat with her and speak to her about her continence issues and all the rest of it. And then I actually looked at her drug prescription, and this lady was on 40 milligrams of furosemide, which she'd been on for several years because she'd got heart failure. She was actually really tiny by this point, so I would imagine she was a much larger lady. So, of course, this poor lady was taking diuretics that make her pee. She was then having to go to the toilet on multiple occasions. Then she was going to get anxious that she wasn't going to get to the toilet, so it became self-perpetuating. So when I phoned the GP up, he was rather embarrassed and did reduce it. And actually, within 4 to 6 weeks, not only was she reduced in terms of her urgency to go to the bathroom, but her confidence and her anxiety was reducing because she knew that she could hold her bladder for a period of times, which meant she could go out of the house. So again, it's about looking for the less obvious and thinking outside the box. And thinking about some of the things that we can really control. So issues and things that associate with functional impairment, for example, the mobility, going back to pain. If you're in pain, it's really difficult to mobilise to get to the bathroom, which then impacts on your continence. Has the person got an accessible toilet? These are all the, is it worth actually having a commode downstairs or in a room that's, visible or accessible? Can the person communicate their need to go to the toilet verbally? And I see a lot of, again, thinking about non-verbals that Wilco was talking about, where, there might be certain wringing of hands or patting or various behaviours or starting to feel agitated, where you can almost think there's something, that they're communicating a need. The dexterity is a key one. Complex clothing is really difficult. And to be quite honest, think about if you've had several glasses of wine and you go to the bathroom and you've decided to put a jumpsuit on, for example. if you kind of think about where we would resolve, I don't want to make light of it, but the reality is these are real challenges. Thinking about the visual and spatial awareness that people might have challenges with, the coloured toilet seats, things like that. If you go into a very beige room with a white toilet seat, it's really difficult sometimes to visualise where the toilet is and things like that. Are they anxious? Again, thinking about other underlying conditions that the person might have. The anxiety might not be associated with the continence. They might be anxious about other things. But as I've already sort of overshared with you, when you get anxious, often that can trigger the need to go to the bathroom. And thinking about diet. Diet can be a really big indicator in changing bowel and bladder habits. We might find that people are not eating particularly well. They might be getting dehydrated. They might actually have a very poor diet, and all of those things will impact on their bladder and bowel functioning. So again, there's some real practical things that we can do. This is Mava, and Mava, again, not her real name. Mava's my granddaughter's name, so I just thought it was a nice name when I'd use it. Mava was a lady who I was asked to see in a care home. So Mava had been living at home independently. She'd had some falls and she'd gone into hospital. She had been diagnosed with vascular dementia, but was still in the relatively early stages of it. Whilst in hospital, she became very distressed and agitated and aggressive. She actually had delirium, but it wasn't really attributed to delirium. It was, it's her dementia is advanced. So whilst in hospital, she was, I'm going to say supported in the loosest possible terms with a 24-hour one-to-one supervision because people were worried about her behaviour. As a result of that, they used to tell her to sit down. So she deconditioned, her mobility went. She was put into incontinence pads where she'd been fully continent at home, and we know this is a problem. As a result of her perceived behaviour, she was then it was deemed that she was required to go into a nursing home. Several nursing homes assessed her and didn't want her because she was seen as too difficult. And then one care home did agree to take her, and she was discharged to their care with a 24-hour one-to-one support. I was asked to review Mava, not because people were concerned about her, but because she was expensive. Her care was costing a lot of money. Now, I went to see her, and I was expecting to see a raving banshee. I saw a tiny little lady in the fetal position in bed, with a carer sat beside her at a higher level, and she sat there and went, "I want a wee." And the carer said, and this is not derogatory to care homes, can I say, because I see this in acute hospitals as well, and in other areas, said, "You've got a pad on." Okay. So this lady was really distressed. I said, "Well, can we get her out onto the commode?" And they said, no, she'll bite and scratch us. So I said, "Well, I'm not surprised. Have you seen how contracted her arms are? She must be in pain. Can I see her drug chart?" Mava was prescribed antipsychotic medication, lorazepam, and she was prescribed PRN Oromorph that she'd not had for many days. I would bite and scratch you if I was in pain and you tried to open my contracted muscles to put me into a thing. So this behaviour had been attributed to her dementia and all the rest of it. So I spoke to Mava, and they said, I said, "Why hasn't she got the Oromorph?" They said, "She spits it out." I said, "Have you tasted it? It's foul." I'd spit it out. It's bitter, it's unpleasant, it's not nice. It's not that she's not in pain and she doesn't want it. She doesn't like the taste, I would imagine. But I negotiated with her because that's the only prescription I had available at the point. I said, "Mava, I know this is really, really unpleasant, but I want to give this to you so it'll help with your pain and we can get you onto the toilet." So she took it. You could see she didn't really enjoy it. I got another couple of members of staff and we hoisted her. I held her hands. There was she didn't bite or scratch me. She looked uncomfortable, but she got on the toilet and she voided her bladder. Despite the fact that this lady had quite advanced dementia, she knew when she wanted to void her bladder or open her bowel, but often she was forced to the point of retaining it because no one was listening to her and they weren't getting her out. Now, I can't think of anything more undignified. The good news is that we got her a pain patch. We got some antibiotics because she was on the verge of being admitted to hospital with urosepsis because she was holding her bladder to that degree. Her antipsychotic medication was stopped. Her lorazepam was stopped. Her 24-hour one-to-one was stopped. And she spent the last 3 months of her life comfortable in that environment. Good care costs less. So I think, again, for me, that's about, not kind of trying to paint a dull picture, but Maeva's not the only person I've seen in that situation. I actually saw a gentleman the other day in hospital when I was visiting my father, actually. And my father hates it when I go into a hospital because I can see myself getting twitchy when I hear people call out. And there was a gentleman beside him going, I need the toilet. I need the toilet. And ultimately, I was thinking, yeah, OK, someone's going to come, so they kind of go, you've got a catheter. And at this point, I could feel my heckles go up. And I thought, well, let's not intervene. And my dad's going, no, Zena, don't say anything. The third time of him coming, I need the toilet. I need the toilet. You've got a catheter in. The voice got louder and louder. So the fourth occasion, I could not hold myself any longer. The nurse came across and was just about to say it. And I said, excuse me, sir, do you need a poo or a wee? A poo? I said, well, he can't do that for his catheter, can he? So again, I think, it's about how we understand the impact of continence on those people we serve. So going back to our couple at the beginning, we were able to change that algorithm. We were able to use the evidence that we had to inform prescribing for the nurses in the continence service. And to be frank, they were really pleased that they could do it because it wasn't necessarily that they didn't want to prescribe it. It was what they were told they were allowed to do. But once we used all this information about the impact of continence, what the evidence base says, we could actually make positive change. And as a clinician, I think one of the other things is not only keeping that learning to ourselves, but sharing it. So as a result of that, I say, I'm not a continence expert. I just feel really passionate about the subject. So, ultimately, we know that there's a skills and knowledge gap. We know that we've got to challenge assumptions, and we know there's lots of myths and misconceptions. And I've been very, very fortunate that as a result of the fact that I'm quite happy to speak up about it, I've been able to inform others about how they can support and change practice and understand people differently. So I don't have none of this has come from a grant, it's just been opportunistic. So we did a Facebook event in 2021 with a continence product company, and we had over 7.7 thousand views of that Facebook Live event. So again, we can get this information out there. I was invited to do a tour of the country, talking to community nurses about continence and dementia. I was really pleased to be part of the themed review that NIHR led as a clinician offering a view on dementia and continence. And I've written several papers in practice journals, not in academic journals, in practice journals and blogs talking about the issue and how we can, as practitioners, really make a positive change and start to change the narrative that incontinence is inevitable in dementia. So if any of you want to talk about toileting and dementia in the lunch break, I'm your woman. And I think as many old school nurses, bladder and bowels are something that we're really quite interested in. So, always happy to have the conversation. So thank you very much for listening.
That's it for this episode of the UK Dementia and Palliative Care Conference 2025 podcast. A huge thank you to our sponsors, Majestic Holidays, Wallens, Amica Care, MC Hearing and Audley, and to Dementia UK for their invaluable support. This series is recorded and produced by iNarrator and proudly hosted by Rowcroft Hospice. Links to resources mentioned are available in the show notes. If you found this discussion valuable, please share it and stay tuned for more thought-provoking conversations. Until next time, take care.